everybody. Welcome back to Psychedelics. Today I am joined by two amazing guests, Dr. Pam Kryskow and Dr. Devon Christie. How are you both doing today?
Wonderful. Great to be here, Joe.
I'm excited.
Thanks.
So you two are doing really interesting work. I just didn't realize, but today I realized that you both actually have practices around chronic pain. So I'm especially excited because that's been a topic we talk about maybe a little too much, or maybe not enough. So I guess let's dig in. How did you two start bumping into each other and decide you wanted to collaborate a little bit?
Well, I think, we may have been put in touch by colleagues. We're both in the Vancouver area and in overlapping circles, but really the night that sticks out in my mind was a hosted psychedelic dinner for physicians in the greater Vancouver area. And at the end of a lovely evening conversation about psychedelics, there was one of my colleagues said, "Oh, I've got a shameless pitch for a study I'm doing. Can if anyone wants to send over participants?" And when he finished, I said, "I have a shameless pitch as well. Does anyone have a ticket to Burning Man?" And down at the end of the table, Pam put up her hand and was like, "I could probably get you a ticket." So that was kind of really where we first started connecting and learned all about our camp, Earth Guardians, which ended up touring down there together. And I don't know, Pam, if you have other details there to add, but it was a great way to meet and to do something together that was really meaningful.
Yeah, well, that's exactly what happened. It was a great dinner, and then it turned out that as we got to know each other more, we realized that we had many of the same kind of pathways, same interests, and we're both really looking for better ways of serving our patients.
Mm-hmm. Yeah, and that was in 2019. And as I recall it, we were talking about psychedelics and pain down when we were at Burning Man. There's a lot of conversations about psychedelics that happen down there, and that shared interest in pursuing some research in that vein kind of evolved, and which led us sort of on the path to the data that we were really graciously granted access to by MAPS Public Benefit Corporation for the study we just published.
Yeah,
That's
yeah, it was kind
fantastic.
of that was an interesting. Again, these things so much happen by happenstance. Is sitting around a coffee table with Alicia Fiducia from MAPS and her commenting like, "You're doing chronic pain. Do you realize there's all this data that has not been looked at?" And that was just like this happenstance comment. And then talked to Devin about it, which ended up then having MAPS grant access to this chronic pain data that was really quite remarkable.
Yeah, and just to be clear, that was the phase two data from lead-in study to phase three. So there was 32 participants that had complete data, pain data collected as a like accessory data, just like let's just collect this because it could be interesting to look at later. Of course, the primary endpoint of the study was the CAPS-5 score for PTSD. But there's a lot. We can talk more about this, but there's so much overlap between pain and PTSD. It turned out that many people in the sample that we looked at had chronic pain, which sort of matches what we see in other studies in the population in terms of the comorbidity of these two conditions. So yeah, we're really, really grateful to have the access to that data and then to work and find a team to analyze it and finally publish it just this past year.
I was in conversation with Dr. Michelle Weiner a while ago out of Miami, and she mentioned her theory that fibromyalgia could be physicalized PTSD. Any thoughts around that? Kind of a weird speculation to have go really far with it, but yeah, what do you think about that?
I think it falls into it as a potential theory, and I think there's a lot. It's so multifactorial, and I think Devin and I both probably see this in our chronic pain patients. Is that there's such a wide range of people. I think we're gonna, be able, hopefully over time, be able to tease this out more fully and get a better sense. And even coming to, what is exactly I don't think we even fully agree on the full definition. It gets adjusted over time with more studies, more research, and how to even give the diagnosis. So I wouldn't disagree with Dr. Wiener's assessment, but I would also say I think there's multiple other areas too that we have yet to disambiguate in this under that category and other categories of systemic pain that is also
Yeah.
connected to emotionality.
Yeah, I mean, fibromyalgia is really like the quintessential condition of this process that's now being referred to as central sensitivity syndrome. And underneath that umbrella, there's also temporomandibular joint disorder, tension headaches, irritable bowel syndrome, and a number of other conditions. And what they share is something that's now being called or referred to as nociplastic pain. And what nociplastic pain is it's referring to the fact that the central pain processing mechanisms in the brain have alterations. So pain processing is actually not happening in a normal way. There's functional connectivity changes in areas of the brain that are, either overactive or not connected as much in certain ways, that pain signals actually ramp up and pain perception changes. And so I do think, there's literature out there, and it's quoted in our paper about how both PTSD and chronic pain might be thought of as like a kind of reactive disorder. I don't really like the label disorder, but what that's pointing to is that there's something happens, right? For both, there's something happens, and often things that instigate pain are also traumatic. There's even overlap in the initiation, and there's also the vulnerabilities underneath, like early childhood adversity and other things that create sort of the scaffold even in the first place. And then so then the there's a mutual maintenance and shared vulnerability models. There's these models that have been written about now about potentially how theorizing how PTSD and chronic pain are similar and have similar mechanisms that perpetuate them. Like mutual maintenance, it talks about, avoiding threat cues and avoidance of certain stimuli as a perpetuating factor in both conditions, and having, altered cognition. So different, maybe catastrophizing around um, certain elements of experience or certain sensations in the body so as to avoid and anxiety, sensitivity, other vulnerabilities that really really overlap, and then the areas in the brain also overlap. So this is part of, like, yeah, really how we see these two conditions are a lot very related. And then I think pain becomes this way to then bridge into other stress related conditions like autoimmune conditions, even where these biopsychosocial approaches like psychedelic assisted therapy may have a lot of benefit.
Mm, that's interesting. Okay. So you both were authors on a paper that came out. Oh man, was it on microdosing and pain, or what was the paper you did together recently?
Our co-authored paper was MDMA-assisted psychotherapy in PTSD shows reductions in chronic pain. That's not the exact title, but it was published in Frontiers in Psychiatry very recently, just this past November.
Oh, that's right. We circulated that a bunch. I recall when that came out. Um, Great. And what can you tell me about that paper? Why was that data important?
Well, I mean, Pam, what I'll say, and I think is the biggest thing, is that as far as we know, this is the first paper published globally linking the potential benefit of MDMA-assisted psychotherapy for PTSD with improvements in chronic pain. So for Pam and I, in our interest in researching psychedelics and chronic pain, it's really exciting, and it starts to give us a foundation for pursuing further research. But yeah, Pam, I mean, over to you on that too.
Yeah, well, for me, that what was really, I think, remarkable when we looked at the data was that number one, we thought people that had the highest PTSD scores would have the highest pain, and that didn't pan out. So this is lovely when you think something and then you get data that tells you something totally the opposite, because then we had to come back and think about it. Well, and then it starts to go, oh, well, of course that does make sense, because if you have such a high score in PTSD, you're not even in your body. You're not feeling things that that's a theory, right? Like that's maybe why people weren't. And then what we were seeing is, as those PTS scores were lowered, people's were scoring their pain as higher. And so, that is what I find really interesting about this, like beyond our study, is it is so helpful for us as clinicians to go that then as we work with people and their PTSD scores start to come down, how we then have to be ready to shift for these other things that may start to come up. Like suddenly now they're somatically in their body, they might start being able to start feeling things that they've never felt because they have been away from their body. Like, there it's such an exciting area to go. Here's another area of being even better therapists by knowing that this is a potential. And so that was quite surprising. And then, I mean, of course, it makes sense that as people's trauma comes down, perhaps that pain, as Devon has eloquently already explained, these connections, as that pain comes down. But not all chronic pain is the same, not all PTSD is the same. And so we're going to need to really look at this under a wide umbrella of different ways. And it's not going to be one size fits all. It's not going to be a technical checklist. And it is these studies too are so important, because people are complex, our patients are complex. And so often science wants to shove our patients into these nice, neat little silos, and you can't do that. You can't do that. So that what was really exciting about this is kind of having our assumptions really questioned and getting a whole nother way of showing up more fully for our patients with this data.
Mhm. Yeah, and where, the link with childhood adversity, the average ACE score in our population sample study was 4, which is a really high score for adverse childhood experiences, which, we know leads to a variety of different chronic illnesses over a person's lifespan. So we did find that in common. But another cool thing about this is that our participants, or the participants of this study that MAPS did, and they were recruited for PTSD. They were not recruited for having chronic pain. So everything we learned about chronic pain from this study was secondary, right, to really what the study was about. And what that does for the data is, these people that came into the study didn't have an expectation about their pain getting better. Like often when you sign up and volunteer for a study, you're like hoping my PTSD is going to get better with MDMA-assisted therapy. And that can create something called expectancy bias in research, which can bias the data and maybe inflate people's estimations of the treatment effect size. Whereas with pain, all they did was fill out this side questionnaire twice, and that was about it. So no expectancy about their pain improving. But what we did with the participants is we clustered them into 3 groups: high pain, medium pain, and low pain. Because again, we didn't recruit for pain. The study recruited for participants with PTSD. So some had high pain, while others medium pain, and others low pain. And so, our most significant findings were in the high pain and the medium pain group. There was significant findings. But those significant findings were a side effect, essentially, of MDMA-assisted therapy to treat their PTSD, which to me is super, super exciting, because it talks about, like, what we've been touching on already is, like, what are the shared mechanisms and what is MDMA-assisted psychotherapy doing that might be translating into benefits for chronic pain? And you start to look at, transdiagnostic factors in healing and such, which, yeah, is super exciting in my mind.
Is there any? Can you say a little bit more on the fact that we're sidestepping the expectancy bias issue with the data set you were working with? Like, does that show that we might have a lot of hope?
Yeah, I mean, there may be even a stronger treatment effect in people that come into a study hoping or expecting their pain to get better with the intervention. It remains to be seen. I mean, it's very speculative, but it's part why Pam and I are working on launching this study of MDMA-assisted therapy specifically for folks with fibromyalgia, because we want to see now if we actually take a group of people that are coming in with pain and using this treatment for pain, then what happens?
Hmm.
And I don't think we need to be too afraid of the expectancy bias or any placebo effect. That is standard, and we know that from the data that that's actually going up. We know that what we had been taught when we were in medical school was around 30%. We know that the expectancy bias and placebo effect has actually gone up, and it's been well documented in psychiatry now. And so the real thing is to go, what is it above that? And truly, like, it's kind of an irony, because it's really a single molecule pharmaceutical model to go, is it working? Whereas every day, every clinician out there is using expectancy and
Oh,
and
yeah.
placebo effect to their patients' benefit. So I think I would like us to have that conversation in a much more intelligent way, saying it's going to be there. It's not a bad thing, and in fact, if you don't have that, you're probably a bad clinician. So let's harness it, and then say, and is the treatment giving above and beyond that? So it's not a
Mhm.
bad thing, because sometimes in this Twitter storms that go out there, people think they've got their aha, I caught you moment. And it's not. It's really not. This is a much more higher level conversation about the complexities of human beings, and the fact that if you are in a study, if you are doing a treatment, if you're going for a nice meal, there's an expectancy effect that you will have a result. So I think we just want to make sure that we really are, again, having an intelligent conversation around that. And then, is our results in the study above and beyond that?
Yeah, which is the quintessential question of research. And I agree completely, Pam. Placebo ought to be part of how we offer good care clinically, because the opposite effect, nocebo, I think, is something that a lot of clinicians don't keep top of mind. And I've personally experienced, when I was suffered a traumatic brain injury and was seeing a insurance company neuropsychologist, and I said, hey, I'm doing vision therapy and it's helping my concussion symptoms. Oh, there's no evidence for that. Why are you doing that? You shouldn't be doing that. That is introducing a nocebo right into my healing path. Well, and I think that happens often, in medicine, with maybe therapies that a clinician doesn't really know much about, or has some reservations or even stigmas or biases around. And I think we might see that with psychedelic assisted therapy, with many of our colleagues. I'm going to go present to a group of pain docs next Monday, and I'm actually quite excited for that presentation. I'm curious how it will be received, but the person organizing it says, "Oh, there's already some commotion, amongst the colleagues." So, um, yeah, it's fun to be on the cutting edge, though, and really trying to open and introduce people to new things.
And what that really speaks to, Devin, I'm so glad you're doing that, because it's really about, like, where's the scientific curiosity? Like, that's
Yeah,
what we need to be. When our patient says this is helping me, we should never be saying no, that's not possible because there's no evidence. We should be leaning in and being curious. Tell me more. And we have a segment of colleagues that don't do that. And that is not the system we are creating now. Like, that is not the evidence informed N of one, listening to our patients. So it's, when we come across colleagues like this, we really have to help course correct them gently and kindly, saying, we need you to have more scientific curiosity. We need you to lean into things that go against your belief system and ask the next question. Why is that? Why is this person in front of me getting a benefit? Why did they do that? Should I have this for my other patients? And I think that really is the cornerstone of any solid pain clinician, is leaning in, going, why is this patient getting better? And why is this patient not getting better? And what else do I need to learn to widen my clinical blinders of what I don't know yet? and learn from others that are. And I think that's why Devon and I think well, I don't want to speak for you, but I know certainly for me why I loved working in chronic pain, because all I looked for is what is working, who out there is getting better results than me, and let me go learn from them. And when my patient says something's working, never dismissing them and going, I need to dive into this. And even if I dove into it and went, oh, it's completely bullshit. Well, I'm not going to take that away from my patient if they're getting better. And
Yeah.
so it's such a great opportunity to be speaking to these pain physicians and inviting you. I invite you to have more scientific curiosity around what is working. Every great study came from great observations, like somebody going, wait a minute, there's something else here that we've missed. That's science. Like, we don't know it all right now, and in fact, we're pretty primitive. The fact that we have a chronic pain epidemic really speaks to our primitiveness in this science. So people should be leaning in.
And like we have a trauma epidemic, really, much undiagnosed because it doesn't fit the narrow PTSD criteria. But I think that's speaking to how our healthcare system needs to pay more attention to the biopsychosocial elements. Even though that's given lip service, it was when I went through medical school over, many years ago. It's still not implemented, at least not here in Canada. Access to the psychosocial elements of the biopsychosocial model to treat chronic illness is just not there in our system. But it does, that's part of why I am drawn to pain, as well as what you were mentioning, Pam, is just within pain, it's internationally recognized that the best approach is a biopsychosocial approach. There's evidence supporting that. So it's incumbent upon us to develop biopsychosocial treatments that are holistic for people, for the 1 in 5, Americans, that live with chronic pain. And so that's, to me, exciting. But then you also still run into, even with my pain colleagues, this sort of way that physicians think about drugs, which makes sense given the history of the pharmaceutical industry, that it's like a pill for a problem, and that a pharmaceutical, like a pain pharmaceutical, is an analgesic, full stop. But when we come to think about psychedelics, there's some education to do there, because psychedelic assisted therapies are not drug only treatments. The drug is a catalyst, and it opens up possibility for what happens in the context of the therapy to have its beneficial outcome. And I have a feeling like that's going to be a concept I need to drill in with my pain colleagues. And I'm sure, Pam, you've run into that too, talking to
Yeah,
colleagues about
oh,
psychedelic
absolutely.
therapies. Mm-hmm.
Yeah, the complexity of the human, and the challenge is we went into medical school thinking we would be able to do this. Like really, like we would have the time. Like I don't know about you, but when I went in, I thought, yeah, I will have all the time in the world to work with patients and really, help rebuild the foundations. And then you get in and you're like, I have like 7 minutes, I have 10 minutes, I have 15 minutes. Like what? Like none of us went into medicine thinking how limited it was. And so, so recreating a new system, like really a new system that says and nobody likes the system. The doctors don't like the system, the nurses, all our allied colleagues don't like it, our patients don't like it. So together, this is really where psychedelics gives a new way of showing up here and saying you are more than this. You are a
Yeah.
complex system that needs everything to be nourished, right? Like, don't we all need that? That's what the biosocial psych is what is your spirituality? How are you eating? How are you connected to nature? How are you connected to your family, your friends, your colleagues, your meaning making in your world? And without that, of course we're going to have 1 in 5 people in chronic pain. It makes sense.
Mm-hmm. Mm-hmm. I think that's where we really line up to, Pam, is just both of us having that mission of really working through our activism and leadership and research to bring forward these ideas and provide substantive evidence behind them to really shift the system in that direction, to one that is much more holistic and does serve people on not just their a physical dimension of wellness, but much beyond that. And it kind of bridges to some of the theoretical reasons why we think the MDMA assisted psychotherapy for PTSD caused changes in pain. I did a little kind of comparison table, or in the discussion of the paper, or we did, going like, well, what do we know about how MDMA assisted therapy works? And what do we know about what helps people with chronic pain get better? And there's like a number of things. I'm happy to go through them. But most of them are really speaking to more of the psychosocial dimensions. But I think what we need to get around too is this mind-body split, right? Mind and body are not separate, and the psychosocial influences of anything will impact and shift our biology. So it's not like woo-woo or not related to a biological mechanism of pain perception. It absolutely is. So yeah, that's also something exciting about the paper, which we can chat about if you're interested.
So you said 5 items, Devon?
Yeah, there's more than 5, but I can kind of summarize if you like.
Yeah, please.
Like we already talked about like avoidance and sort of the avoiding things that would trigger pain. And we know that MDMA helps with fear extinction and actually helping people to approach things rather than avoid things that are negatively charged. So MDMA helps with that approach versus avoidance. And it also enhances self-compassion, which we know when people in pain have more self-compassion, they have better outcomes. It also changes things related to reduction in self-criticism and improving sort of social interpersonal attitudes, more interpersonal connection, which when people in pain are socially isolated, their pain is worse. And, things like social roles, meanings, purpose, all of that gets challenged when we're living with chronic pain. So they're really actually quite relevant treatment targets, which we know MDMA can address. And so, there's also some cool neuroplasticity things like the potential of MDMA to reopen critical period neuroplasticity, like a younger state in the brain when there was a potential for a lot of connections to be made related to social learning. And we know that those periods are times when we really develop a lot of resilience, right? Our capacity to respond to stress is so much influenced by the security and the health of our attachments in our social environment as children. So if MDMA reopens that, maybe there's this opportunity to really lay down some new wiring, some new pathways that are going to help people in pain have a much greater sense of resilience, and that whole relationship to stress might change. So those are some of them. But yeah, I think you kind of get the idea there of how like MDMA, it's a perfect drug for PTSD. And I think there's a lot of ways that translates for pain.
Well, it's a great drug for the ACE scores too, right? Like when we
Yeah.
saw the ACEs at 5, at 4 and above, like that, the reattachment, the opportunity to be reattached, to be re-nurtured at those seeds of trauma that come at those young ages, right? To really rewrite them, create a separation that no longer defines who you are, or how you bring that forward into your adulthood, and really be able to, even though those events happen, to be able to go, it happened, and it no longer defines me going forward, in a way, in this space that you get to be in with these medicines, to know it fully, to feel it fully, that love or that attachment, or that it wasn't your fault, or multiple ways.
Mm-hmm. And likely those kinds of changes are the kinds of changes that are going to interrupt and rewire some of the faulty wiring that we see in nociplastic pain in the brain on chronic pain. That remains to be seen, but I just can't wait for more functional magnetic resonance imaging looking at like what's happening, in the pain brain versus the brain and MDMA, and in the MDMA-assisted therapy environment, and are those changes actually functioning to help, on that level. I mean, it's one way of understanding, and it does it. It's, if there's an outcome, then great, it works. I've got lots of colleagues that say that too, and say, like, forget the functional neuroimaging, as if you need that when when you've got an outcome. But I like to understand. I think it helps us evolve in an interdisciplinary way to speak a number of different languages about how these things may be working.
Absolutely. You mentioned critical period reopening. I think Gould-Lynn did a lot of work to make that much more popular concept. And one thing that really blew my mind in discussions with Gould-Lynn was something around MDMA somehow working around brain networks, working more at the molecular level than necessarily, amygdala, different parts of the brain. And she got this through her octopus work, which is kind of interesting. But I don't know, any thoughts on that relative to pain in the performance of MDMA? Super technical, I can say that for her.
I think it's more just remains to be seen. I mean, anything there would be, really extrapolating. We're still learning and understanding about nociplastic pain and even what like defines it on that level. So I think it's just as we gain perspectives through that kind of research into how these drugs might be acting, and then in parallel are learning more about changes occurring in a particular brain in somebody who's suffering with chronic pain, for example, we can start to kind of make those connections. But I don't really have too much to speculate on at this point with that, other than what I've already shared, which is the social reward learning and, just that window of potentially getting into the deeper layers of the capacity to self-regulate, right? Which comes through co-regulation in a healthy, nurturing environment. We're not born with the capacity to regulate our own nervous systems. We need a regulated external nervous system so we can learn regulation and develop the prefrontal regions where we can inhibit reactive impulses and, not. And when we don't get that, we kind of take on and almost like duplicate like the stress brain of the stress dysregulated person, maybe that was holding us or maybe not even holding us when we were little. So opening that period and making it potentially open to extremely open and sensitive to new learning in MDMA therapy, where you have a nurturing environment, the opposite of what was missing, I think is just really profound as far as some of those deeper limbic circuits and ways of, how we relate to ourselves and our experience that are going I anticipate we'll find are very relevant in chronic pain.
I'd like to jam on a little bit of what you said too around the imaging and ask about is again, we are really primitive here. We keep trying to extrapolate from these studies of what we think, and then they innovate to another level, and then we do so much imaging, and yet so much of what we know from the imaging is theoretical. Like we get a beautiful brain map, published on the default mode network, and it's already kind of by the wayside, yet it's still being quoted over and over and over in popular media. So these things keep moving, and they are really theoretical. And I think it comes from the scientific wanting to know, how does this work? How does this complex thing on our shoulders work, and how does it interact with the body? So my bias is actually away from spending too much of our precious resources on that, until every time I meet with imaging teams, it's like, how do you know what your imaging means this clinically? How do you know that if you see this means this in a patient? And they're like, oh, well, we're not there yet. So we have to keep that in mind. We're not as far along as we think we are with these things. They're very interesting, and the curiosity is high. And we still have to look at the person in front of us. And ultimately, that is going to determine the success of what we are doing. And we're still going to ask these other questions. But I think it's really important for your listeners and your watchers to know that, we don't know as much as we think we know around this. This is still very theoretical. Mechanisms of action are almost all completely theoretical for almost every substance we use. And, it's just keep that in mind. And we can also believe the patient. I think we can just believe, are you better? Do you feel better? What does that look like? While we try to become more sophisticated with these other measures.
Yeah, I agree. And it's like even with a psychotherapeutic interventions, right? There's different modalities of psychotherapy, and we could get into arguments about the evidence of one over the other or whatever. But it's kind of just like, are eggs good for you or bad for you? And there'll be a paper, or smoking, or like alcohol, or any of there's papers that prove it one way or the other, and it bops back and forth. I think what's more important is to like boil it down. Like, are there common factors? Like, what are the common factors across psychotherapy modalities that tend towards better outcomes? And that's like the quality of the therapeutic alliance, the feeling of trust in the practitioner, and the ability to be open and vulnerable. And these are the things that we should start to collect around as we're developing interventions. And so, yeah, if we're spinning off into like these deep eddies of molecular mechanisms or like specific functional connectivity networks, yeah, it's interesting and it could get us somewhere, but let's not lose sight of the potentially kind of like larger picture that all those things could fit into in certain ways. I did hear about a study. It's been a while now since I spoke to these colleagues at, I believe it was at NYU, because they were looking at fibromyalgia as well, with MDMA as the only other group that I'd heard of developing a protocol. And they were going to use scanners, and actually they're specifically wanting to understand what about the therapeutic alliance under MDMA might be important, or could we characterize in scanning the brain of the therapist and the participant while the participant is under the effects of MDMA. Technically, I'm kind of going, well, then how are they, if they're both in the scanner, do they have like a video? How do they talk? How do they see each other? But it's so cool. Like, I was very happy to hear that there's researchers out there, wanting to understand more about the quality of the connection and that relational environment, because I do believe that has a lot to do. It's one of those extra pharmacological factors or aspects of context in psychedelic therapy that I think is extremely important. We need to understand more about. It's not talked about a lot.
I'd love to see people, qualify things as more theoretical more often. To your point, Pam. So thank you for that. Yeah, I just feel better when people are a little bit honest about the uncertainty. And I think we could probably go further together if that was, done more regularly, perhaps. Yeah, this is all over, right? It's not just a mechanism of action for 5-HT2A psychedelics, but it's all over.
I think that comes with, I hope that comes with as we get older, and it's certainly something I see in my wise mentors, this humbleness to science, this humbleness of, I know nothing. I know less now than I knew when I was your age. I have learned, to be more circumspect about what I say I know versus what I think I know. And so I'm very honored that I have wise mentors ahead of me that I can watch on this. And this is what I've seen consistently, this humbleness to science, asking the next question, not just accepting things like, oh, of course that's the mechanism. No, well, is it really the mechanism, and why is it the mechanism? And it's not a challenging way, it's a curious way. It's a leaning in and asking, and listening to learn and listening to ask, and really developing that scientific mind, getting. And I think that's really what we can do here with psychedelics a lot more, is be a lot more friendly, a lot less ego driven, a lot more collaborative, so that really good science gets done. And also it science is getting done with a lot of people being brought along. The patients have to be, front and center of writing what the science is and how the questions are asked and how we proceed, and having way more researchers, like, we're community researchers. I think this is exciting. This is a kind of research we need more of. We need more people that are actually hands-on patients writing these studies, and taking them through the process, and mentoring up other young researchers to do it. Like, these studies have to be done really well and in the community, and who better to do it is than people that are actually interacting with patients and really hearing their stories.
Well, this is it, right? Because science, the argument I've heard so many times that is made by my physician colleagues is, oh, there's no evidence for that. But where does evidence come from? I mean, first of all, the questions that are being asked, well, who's influencing the questions that are being asked? Who's the dominant voice asking the questions? Because science will only answer the questions that you ask. So it's based on what science has already shown, often informs hypotheses, but it's also, this is where, uh, diversity, equity, inclusivity lens is so important to take into this. It's like, well, what questions are not being asked because people's voices are silenced? And I think that that's partly why I'm excited that for our collaborative project, Pam, that we're working on to look at MDMA-assisted therapy for fibromyalgia, we're being supported by People Science, which is a new contract research organization in the US. And their whole mandate is actually to help clinician researchers and people in the community ask questions that are relevant to them and relevant to the people they're serving, which I think is a really important thrust in science and what questions we're asking. And we have to look at our methods too, because homogenizing through, trying to do the randomized controlled trial, you end up sort of sterilizing to isolate one specific variable and trying to make your study population as similar as possible. And in the real world, that's just not the case, right? In the real world, people are on 10 different medications and so what's really even the applicability when we sterilize and homogenize so much, what we believe is giving us the best evidence. So methodologies also need to be questioned. And I really think qualitative and observational methods, case studies need to have more weight that they don't have right now in our community, as in physician community at least.
Yeah. We have a big soapbox on this one. We
Oh my
have
gosh,
been
we sure
on
do.
this for a long time.
Well, anything further on this idea of maybe critiquing the notion of evidence-based practice a little bit? I'm liking the term evidence-informed these days.
Mm-hmm. Yeah. Well, I don't think we need to critique. I think all science is science. You just need to look at it. Is it relevant? So what Devon was just talking about is if I have a patient in front of me and I have to go to a randomized clinical trial and make a treatment recommendation with them on their decision making, that population may not apply to my patient. Just like Devon said, it's been scrubbed clean to have one problem without any comorbidities. Our patients have multiple comorbidities, especially in fibromyalgia, and this study that we're working on together. And so that really, you don't have to push aside another study. What you need to do is look at it and go, okay, what of it is applicable? What of it is useful? Like, there doesn't have to be, like, there's a lot of, it's kind of it goes back to something I said earlier. Like, there's kind of this, like, in science, like, not good studying, not a good layout, like, not a good protocol, blah, blah, blah. Like, instead of just going, what of it is useful? And then improve upon it and do something more. It's not a better than, it's not an argument. It is a process constantly rolling forward. So we don't have to be mean or critical or putting down our colleagues. Just go, yeah, great for you actually doing research. Research is hard to do. It takes a lot of your time. You don't get compensated for most of your time when you do research. It's really a labor of love for a lot of people. And so then how can we build on that? And then go, what do we need to do? And that's why I love this study, because we both have seen fibromyalgia is so challenging to treat. MDMA, as Devon has already nicely lined up, fits nicely into that trauma. We already have the evidence around PTSD. If in fact, like Dr. Wiener, like you mentioned earlier on, if that's a part of it, then great. We're right in the sweet zone, and we're going to get a lot more information. And this is not going to be a perfect study. It is going to advance knowledge based on the patients that come into the program, the therapists that are in the program, and the data we collect. And that's exciting. I find it super exciting to be able to start really getting some of these psychedelic medicine, or entheogens here, into research around chronic pain. I mean, this is where our hearts are. We want our patients not to need us. And if we can add a piece of data here that will help patients and open the doors for this patient population to get access to a medicine that can help them, then what a privilege.
Mm-hmm. And MDMA-assisted therapy is in its totality a biopsychosocial intervention. It's like a complete package, right? You've got the drug that exerts some biological effects that causes a shift in altered consciousness that then is open to environmental inputs, where you've got a therapeutic modality, which we're designing the study according to the standard MAPS protocol for PTSD, but there's going to be some priming in the preparatory periods about the brain and the neuroplastic changes that happen in the brain with chronic pain, and why the psychosocial elements are really relevant, and that's a conversation I have with my pain patients a lot when I'm suggesting that they take our mindfulness program, for example, to help them change how they relate to stressors. They're like, well, what does that have to do with my pain? And there's sometimes a fear that as a doctor, what I'm saying is that your pain isn't real, or your pain's all in your head. And that would be a drastic oversimplification, because what is actually the case is that there's, as we've mentioned already, pain perception is a biopsychosocial phenomenon. It's very complex, involves many different parts of the brain, the central and peripheral nervous system, and it's all real. Like, your pain's real, and I'm suggesting and inviting attending to stress and how you relate to stress, because it's the same parts of the brain that are processing your pain. And so we're going to kind of weave that into the prep, so that what happens in the MDMA sessions, whatever content surfaces, it's still going to be that inner-directed or non-directive therapy, but there may be some ties to the relevance, whereas they may not have been open to that or understanding of that if something comes up around a painful, psychologically painful thing that happened, maybe, to work through. So yeah, it's really fun thinking about how to do this as a pilot, to then be a platform for further research to then build upon.
So you have the study that you're trying to execute on. You've got, some partners there. What can we hear about the upcoming study?
Pam, do you want to start?
Well, what we it's like Devon said, it follows the MAPS protocols. It follows the same treatment modality, the same preparation, the therapy, the integration, all the way through. It's very consistent, and it just has different primary endpoints on it, which are related to fibromyalgia. So as opposed to
Mhm.
pulling it out from the other study where we looked at the pain, but the treatment was for PTSD. Right now the primary endpoint is fibromyalgia, and it's
Mm-hmm. Yeah, and things relevant to fibromyalgia. We're going to look at questionnaires that also, might highlight where participants in our study may have other comorbidities under the umbrella of central sensitivity, like IBS or tension headaches, some of those others, or chronic fatigue that I've mentioned earlier. And it'll be interesting to see if those might shift too. And also, and this links back to our discussion of evidence, having some uh, opening in our data collection for the voice of the participant, as far as having like not just quantitative data analysis based on validated screening instruments, but also having a qualitative element where the voice of the participants, like, how was this meaningful for you? What really worked for you? What could have been different or better, these types of things we can also pay attention to, because I think that's really important for informing future approaches. Not, it's like, what's relevant to them, not just what's relevant to me as a researcher. Yeah, I've had pain, and I know chronic pain well personally, but I'm not them. And so that I think will be also something that's really adds to what this study can offer in kind of a very nascent and emergent field in psychedelic assisted therapy, in expanding indications into this pain indication.
Yeah, taking it forward, right? It's a first step. It looks at something that hasn't really been looked at super well, and then we iterate and we go, what's next? We take the learning from it and go, what's next, and really start filling in some of the knowledge gaps around pain and how these medicines that are coming back into medicine can be helpful tools. And we're going to see a wide range of information, I'm sure, coming back. I'm sure some of our theories and our beliefs are going to be challenged, which is exciting. And just take it forward. I mean, ultimately, both Devon and I want our patients to feel better. We want them to have more choices. We want them to have more life in their life and less doctor's appointments in their life. And so, if any part of this can bring that forward, that's great. But I don't think either of us are going to stop here. We're going to get some learning from this, and we're going to take it forward, and we're going to take it to the next level, and then to the next level, and to the next level, and just keep going. That's science.
Mm-hmm. Yeah, and it's colleagues around the world are looking at fibromyalgia as an indication, but with other psychedelics. So there's work happening at Imperial College London, psilocybin for fibromyalgia, and elsewhere. And so I'm really excited that work is starting to happen around classical psychedelics and their application in this particular population. And here we are adding in the piece around MDMA and how that might contribute, and then starting to see like, where do our results overlap? Where are they different? And I think we're just in the next 5 years going to have so much more information with the work that's just getting started now, and it's just very exciting to be working on this at this time when this has become such the focus of my medical practice. And every day I see patients that suffer and don't have any other options, and to know that I'm a part of this with Pam and trying to create more options is meaningful. It's really meaningful for me as a physician, and then also how that might translate into some of the systemic change we also both hope to see happen.
That's fantastic. I can only imagine it's frustrating to not always get the results you want with your patients, right? Sometimes folks have to be on chronic opioid meds for 20 years in some cases, right? Which is, not necessarily immoral. It's just like a little dangerous, maybe, like a little bit of risk. So yeah, how do we just keep evolving this? And I love your approach. Like, we do have to iterate here. We do have to do things. We have to do research that's imperfect, and people should understand that's part of research. To your point earlier, Pam. And yeah, even a bad study moves science forward. We say, okay, great. Let's not do those things again. Let's do it better. And methodology is always improving. I even read a paper recently about a lot of psychometrics used in clinical data around psychology, psychiatry. The measures are just that we're using regularly. People don't love them. Like they're.
Oh, this is such a good. I want to jump on this.
Please.
This is such a good thing. So, on with the microdose.me study that I'm one of the investigators on. As soon as we launched it over the year, we had so many people saying, "What about this? What about this?" And I met with so many patients, and exactly what you're saying. I hate doing the PHQ-9. It makes me depressed. And I'm like, oh, wow. And I'm not going to argue with them again. I'm going to lean in and go, tell me, okay, can we have a coffee date and you tell me how you would prefer to ask the question, have the questions asked, right? This is patient-oriented research. And this is, and keep it, and like Devon and I, disclosure, like Devon's already mentioned, like we both have come through chronic pain. So, I mean, that's a lot why our hearts are here. So we're kind of patient-oriented researchers too, in a way. But the patient voice is so important. And these validated studies are all done from the clinician standpoint. And that's okay. Now let's change it. Let's make a better system. Let's make it even better. Like we can learn from that and then recreate a better system from it. So, love working with anyone that says, I don't like the way you're asking that question. Great. Tell me how to ask it. Tell me what works better. What does empower you to have and in pain too. Pain is such a tough one. Like, I have been rewriting pain scales over and over and over to fully capture what is a patient experiencing, and what is the best way to ask it, and even how do we know if it gets better, really, right? Like, the BPI that we often use, brief pain in our inventory. You may see a patient and they're clearly getting better, but their scores are the same, right? Because they've acclimatized to their
Mm.
new normal. And
Yeah.
so these measures are imperfect, and that's okay. That's okay. We'll lean in and we'll find a better way of asking. So if patients don't like what's happening, we're all in to listen and say, how can we do it better? How can
Yeah.
we make this even better?
Yeah. Yeah. And in measuring chronic pain, and tracking and helping our clients, our patients, some of I think the dominant voice now in chronic pain management is it's not about necessarily getting rid of pain, but it's learning to relate to it differently, live with it differently, function in your life, and all of that. And there's a parallel here, I think, with PTSD. In psychiatry, is PTSD is like, okay, well, it's a chronic condition. People need to learn to live with it, and how can we like mitigate the symptoms so that they can be functional and enjoy relationships again, maybe. But then the MDMA research for PTSD is actually really challenging that view. It's like, no, actually, maybe this is a condition that people don't have to live with for their whole life. Maybe we need to start thinking about not only PTSD, but chronic pain potentially as like something that people can actually have close a chapter on in their life, and then move forward and actually have a hope of a cure, right? Or being able to actually live free of symptoms. And I would like to keep that as a North Star, because I believe in our capacity to change and the neuroplasticity of our brain, and the power of having the optimal inputs and the supporting a person's healing just by creating the optimal environment and learning what that is, as opposed to imposing, this is the treatment and this is the structure. And if you don't fit into it, well, too bad, just do, which is sort of what we see a lot in the dominant system in medicine. So I think there's a lot of hope for the future, and we need to keep our minds open about what's really possible.
Mm. Yeah, agreed. Folks don't like the cured word to be used.
Yeah, I know.
And we're leaning towards that. Psychiatry traditionally hasn't
Yeah.
had cures. Lobotomy probably, but I don't know what that's curing.
I think people do like the word cure. We're just so hesitant, but we see cures all the time in our psychedelic programming. We see it all the time, where people's scores are just drastically better, and they get on and they're like, I'm good, thanks. And you're like, it's fantastic, right?
Mm-hmm.
It's not everyone, and there is a whole spectrum of response. So we have to be very careful about that. And it is possible. It
Mm.
is possible. So, and really, that I feel that it's really just our limitation in maybe our resources, our learning, our techniques, that we have to keep iterating till we get there. We never stop. It's not good enough for us to have patients still in pain or still with PTSD or with depression. We have to keep iterating and drive this forward. And hopefully, we'll be able to use cure more and more and
Mhm.
more.
Yeah. I think more, of course, from a scientific standpoint, when you're developing a new therapy that's controversial, like MDMA-assisted therapy, of course, when speaking with media and people, you have to just be cautious with the word and the language you use, because that a cure may not be scientifically proven. Or you say, that 67% no longer meet criteria for PTSD. That I think like another level, if we were to get a little bit more meta about cure and what that means, is also breaking out of the dominant paradigm's way of individualizing people's problems and their pathologies. Because if we really look and open our eyes, in many circumstances, the pathology is not individual whatsoever. The pathology is in our culture and in our society, and how disconnected we are, and the intergenerational trauma that's passed along, and then parents without support, and no hope of not passing that along, because our society isn't providing the optimal environment on a societal level for us to be thriving, right? So I think like a cure on an individual level needs to be couched within thinking about a cure on a collective level for what is even driving the epidemic of pain and the epidemic of trauma and all of those things. I think we also just need to keep going, okay, and then how does this bridge to a bigger collective solution?
Got a final question. How do we intelligently think about microdosing? Because right now it's like the mechanism of action and all this kind of stuff. People are so quick to shoot it down. I'm pretty optimistic about it, but I don't really have anywhere to lean. And we know that there's been some good data. The Castellanos UCSD group had some microdosing reported to, I think it was psilocybin microdosing, helping people with chronic pain as kind of a maintenance thing in between macro sessions. But Pam, you're doing a lot of microdosing work. I'm really kind of curious your thoughts here.
Yeah. Well, in the microdose.me study, we have over 22,000 people. And that's the whole point of it, is to go, like, what is a prospective observational, like the prospective observational study, looking at why are people microdosing, and, what are they microdosing? What is the frequency? What is the dose? All those parameters. I mean, we're talking about substances for the most part that are not legal yet. And so the only way to study them is this way, are in clinical trials. But if you can get 22,000 people in a study and you're looking at them, you can start to see where the signals are, and then you can design really solid clinical trials. And when we do a full review of all the trials that have microdosing in the title, the majority of them are actually not. They're in dose ranges that would be considered intoxicating. There are also on regimes that people don't follow. One microdose in 2 weeks is not really the regime most people follow, regardless of the medicine they're microdosing. So that's a big challenge. Is it's hard to have a scientific opinion based on any studies, because there haven't really actually been any really solid studies that actually mimic what people are doing in the real world. And so until we get to those studies, then we should probably abstain from having too strong of an opinion and be curious. And the interesting thing, what I find, the reason I got involved even in the research, is because so many of my patients were coming to me and saying, I am microdosing, it is helping. So it goes back to, do you believe people? And I personally believe my patients when they say that. And I had so many folks that I knew that had adult onset ADHD that were using LSD so that they could focus. And I think people don't do things that don't work. And Jim Fadiman says, if it doesn't work, it's kind of like one of the weirdest worldwide phenomenons that continues to grow for something that, like, things generally, you don't keep doing things that don't work. Even if it's a fad, people generally fall off of it. So we'll see. Anyways, I think we have to be scientifically curious. The solid, trials that actually follow the dosing, the scheduling, and the indication. A lot of the trials were also in healthy normal. So how much, what do you expect to see in a healthy normal? So anyways, the rigorousness isn't there yet. And my bias is to believe my patients. So when I have people coming in and saying, I'm out of bed now. I used to lay in bed for 18 hours a day, and now I'm out. I bought a dog. I'm exercising. If it's a placebo or expectancy, awesome. I'm gonna celebrate that. So
Beautiful.
yeah.
All right.
Hard to say.
I appreciate it. I could comment all day, and that's a whole big conversation in itself. So I just want to say thank you to both of you. Is there anything else we want to leave folks with?
Well, I want to appeal to the listeners regarding our proposed research, because We mentioned this is being supported logistically through People Science. And as far as financial support for this research, we are launching a crowdfunding campaign. And so this research is going to cost approximately $1 million, Canadian dollars, to carry out. And we need to raise that. So for any of the listeners who have chronic pain or know somebody in chronic pain, or have been connected to it and feel that they want to contribute to putting some dollars towards a very important platform for further understanding and potentially a new treatment paradigm for a very, very complex condition, fibromyalgia, and then potentially extrapolating to other chronic pain conditions, we would love their support. So, it's been very meaningful for me to be a donor to MAPS Public Benefit Corporation and support the PTSD research since I learned about it, more than a decade ago, ongoing donor, because it's like, this is putting something really good in the world in a language of science that is important for a lot of stakeholders and decision makers and funders. And, so I really see that this research that Pam and I are setting out to do is very important. And we would love to have some folks support us in carrying it out.
Beautiful. And how can they reach out? Please go for it.
Right. Well, we very generously have been just found out that Vancouver Island University will happily receive the funds as a charity in Canada. So the Center for Psychedelic Research, actually, it's got a much better name. It's a NASA Center for Psychedelic Research. So it has been named by an Numinus elder, meaning better together. So it's a better together, two-eyed seeing approach, bringing in Indigenous ways of knowing, Western ways of knowing, and co-creating a better system. So it's the NASA Center for Psychedelic Research, or the Center for Psychedelic Research at Vancouver Island University, and they will collect the funds for the study for us, and without any fees. There's no fees, so all the money you donate will go directly to the study to be done.
Mm-hmm. And, we just jumped into this podcast, and didn't get a chance to acknowledge the territories that we're calling in from, which is something that, is a really important act, for me, of just reconciliation and really acknowledging that I'm standing here and I'm living here on the traditional and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh people who've been here since time immemorial and stewarding the lands. And it's a privilege. And I'm also here with humility to learn. And I think, many of the Indigenous teachers and elders that I'm fortunate to be in contact with have so much to contribute. And we know collectively have so much to contribute, especially even to this field of psychedelic assisted therapy and healing. I just wanted to acknowledge that before we close as well.
Thanks for bringing that. And I'll add that I'm on the traditional unceded territory of the Klahoose First Nations, and I feel very privileged to be able to live and work here.
Beautiful. Well, thank you both so much for spending time with us, educating us on chronic pain, doing some really impressive work around the MDMA aspects, microdosing, respectively. And yeah, thank you so much. And I hope we can keep helping you, and I hope you get all the funding you need to execute soon.
Thanks so much for supporting us in this. It's so appreciated, Joe.
Absolutely.
Thank you, Joe. It's been fun.